high school students. They're so impressive. I really want to congratulate Caroline He and the WeSTEM organization for all of the great work that they're doing. Now I'm delighted to invite to the stage our final panel on enhancing healthcare with AI, innovations in detection, drug discovery, and personalized medicine. It will be chaired by Associate Director of Health at Citrus, Gale Berkowitz, and I'll ask her to come to the stage with her panelists.
Great. Good afternoon, everyone. Thank you for all staying around, and you won't be disappointed by staying to the end of this. This session builds on everything that you've heard today. In fact, I'm going to roll it back to Monday morning, starting then. As I was listening all through Monday and through today, I was just thinking of our conversations and what we're going to be talking about, and I think you'll appreciate it. I love being asked to organize sessions like this. I feel like it gives me the chance to set the question and the title. And then I get to pick the people that I'd like to speak to those questions that I have on the issues that I care about. And so that's what I got to do with this, and that's how we got to these three people that are sitting here today. And there's such a relief and excitement when they say yes. So thank you all for being here. And it's a privilege to be able to do this. Our official topic, enhancing healthcare with AI, blah, 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 a long one. Some of you that have worked with me on this session know that I struggled with that title a bit, and I think originally it had harnessing in there, and I knew harnessing wasn't right because I know we can't harness AI. But it was the social media post that I think just came out last week, or even the beginning of this one, that came much closer to it, that was saying, what is the role of AI in health equity? And I think that comes much closer to what we will be talking about today from three different perspectives. So let me get on with introducing our panelists. I know you have access to their bios, so I'm not going to read it all, but what I wanted to highlight really is about the backgrounds from which they came to get here. I'll give it away now, none of them started out in tech, but all of them are steeped in it on a daily basis. Our first person will be Courtney Lyles. She's the director of the UC Davis Center for Healthcare Research and Policy and professor of public health sciences at the UC Davis School of Medicine. As a trained health services researcher, she has expertise in health equity, digital health and informatics, and implementation science. Her research portfolio designs and evaluates new programs and platforms to support patients and families, as well as clinical workflows with an emphasis on patient, participant, and community-engaged methods and chronic disease prevention and treatment. To my right immediately is Adrian Aguilera. He is an associate professor in the School of Social Welfare at the school at UC Berkeley and the Department of Psychiatry and Behavioral Sciences at UC San Francisco. He directs the Digital Equity, Health Equity and Access Lab, DHEAL, at UCSF, and he directs the Latino Mental Health Research Program and co-leads Solve Health Tech. He is trained as a clinical psychologist and is an expert in cognitive and behavioral approaches to treating depression and anxiety. His research is focused on developing and testing technology-based interventions to address health disparities in low-income and vulnerable populations. His work is focused on utilizing mobile phone technologies and data science to implement mental health interventions. And he's passionate about leveraging digital health for equity. In the middle, we have Veronica Ahumada Newhart. She's the director of the Technology and Social Connectedness Lab and assistant professor in behavioral and health informatics at the UC Davis School of Medicine. She holds expertise in health and human development, health informatics, health equity, team science, community-engaged research, and human-robot interactions. Her research focuses on human-centered design, of digital and telehealth interventions to improve health outcomes, reduce health disparities, translate emerging health technologies into practice and informed policies. So with that, we're going to start with Courtney. Each of them will give you some background on themselves, on their work, and their point of view. And then after that, we have some questions that I would like to ask of them, and then I would like to open it up to questions from all of you. So pay attention and write down your questions.
Great. And did you want us to use a slide, or should we just?
Yeah.
Yeah, should we?
Well, the clicker. Okay, great.
I didn't know where the clicker was.
Okay, we got a clicker. You can pass through that and that. There you go.
Yeah, I'm first. Okay. Great. Thank you so much. I think my mic is on. Great. Thank you for inviting me, Gale, and thank you for the organizers of the conference. It's lovely to be here. As she mentioned, I'm directing not a new center. I'm new director of a center at UC Davis, but I spent the last almost 12 years at UCSF. So I'll talk a little bit about some of the research I've done in San Francisco and what I'm going to be bringing here to Davis and Sacramento and the Central Valley in the coming years. So I'm trained in public health. I have a PhD in public health, but I've been based in medicine for my entire academic career. So I think this builds well on the last panel because it's really trying to bridge different disciplines and also trying to be at the point of care and really think about the real implementation of solutions. So I didn't come to informatics by my training. I came to it as more focused on health equity, focused on health communication, and I realized that informatics and digital tools were going to be the way in which we were going to have to be able to transform equity. And how were we bringing different patient populations to the table and really thinking about that. So that's a little bit about my background. And that leads me to, so I just have one slide, so don't worry. It's very busy, but I just have one. That leads me to sort of why I take the kind of approach I take in my work, which is on the left-hand side of the slide. So because of how I'm trained and because of what I do, I really spend a lot of time thinking about the many levels of influence on what we're doing in digital health and what digital health equity looks like. So we often sometimes think at the individual level, right at the center of that circle, do people want tools? Do people want to wear sensors? But obviously that won't work unless they're in trusted relationships with family members or clinicians or others who want to encourage them and support them in using tools. They live in neighborhoods and environments with community-based organizations or infrastructure that also enables them to be able to use platforms and tools. And then we have policy solutions that actually allow them to go online. And a real simple example of that is telehealth during the pandemic. We saw lots of telehealth roll out, a really exciting time for something I've been working on for many, many years. And when you look at the uptake of it, it just looks completely different at a public hospital where I was based at San Francisco General for the past 12 years, and what it looks like at an academic medical center like UCSF Med Center. And very, very few video visits being done at San Francisco General, less than 1%. And more than half the visits were done via video at UCSF at the same time. And if you look at that at face value, you might say at the individual level, people didn't want video visits or they weren't able to use video. But if you take a multi-level lens, you would realize there's many, many reasons and many layers why patients who are served in public or safety net serving institutions are less likely to be able to use it. Was their clinic ready to use it? Do they have a broadband built into their communities? Do they have devices and access and affordability, right? There's just so many layers of an onion that I could talk all day about. And that's what I try to tease apart in my work. And then I won't get into the middle too much, but just to give you an idea, you can tell then, being somebody who has sort of a multi-level lens on equity, it means that my research just spans all sorts of domains. I'm really interested in design, which I know both of my other panelists have a lot of passion for as well, how to design things in different formats and different languages to meet the needs of users. I'm really interested in real-world workflow implementation. So what does it look like at a safety net system in particular to implement a new technology and have staff and nurses and clinicians want to engage with that technology, and how do we study that? Really interested in evaluation, so not just randomized trials, which are great, and I do them, but also other types of evaluation of real-world digital evidence. So we roll things out. How can we increase the rigor of what we're doing in the real world at a speedy pace, while also really generating evidence about the effectiveness of that tool? And then lastly, I already touched on policy, which is really about how do we align incentives? How do we align people's priorities? So I think a lot about policies for broadband and others, but this paper that I put here is an example of industry and public sector priorities. How can we get on the same page about what we're designing and what we're implementing with companies, big and from startups all the way through large companies? How can we align our incentives to actually be centering equity in what we do? And then that concludes with an example of a study that I'm running now. Is about remote blood pressure monitoring, so that's sort of the chronic disease implementation, but how do we do that in 25 primary care clinics across the entire state of California, in San Francisco County, in Contra Costa County, and in Ventura County. We're gonna use 25 primary care clinics and public delivery systems to use cellular-enabled blood pressure cuffs for patients who speak English and Spanish, and then randomize those clinics to get clinic-level support to be able to take in home blood pressure readings and really use them at the point of care. So that's sort of an example of that multi-level lens in a PCORI-funded study that we just started last year. So, I know it's a little bit of a whirlwind, but trying to just give you a flavor of who I am and what I'm up to.
Thank you.
Yeah. Oh, it's Adrian next.
Adrian. I think so. Let's see. There you go.
All right. All right, I'll skip this one. It's kind of broad overview. Beyond just saying the general gist, the motivation for my work is really thinking about, trained as a clinical psychologist, how can we improve mental health, particularly of typically underserved populations. So focus very much around behavior and really bridging innovation with equity. So oftentimes those two things exist separately, or one comes first, then the other comes. And I really think about doing both at the same time. I think that we can both learn more and develop better innovations, and we can improve equity only when two are intersecting at the same time versus other approaches that often don't work, let's say developing innovations, and then trying to adapt into new settings, right? We find that trying to fit those squares into the round pegs doesn't tend to work. So that's generally kind of where my approach starts. And I started this work doing text messaging interventions back in 2009, mostly because that's what was around, and that's what the users that I was interested in were using. I wanted to work with folks in the community who are primarily Spanish speakers, primarily immigrants, who didn't have access at the time. Not everybody had smartphones, but particularly those communities. So I've always thought about how can we reach the broadest group of folks who are in need. And it really taught me to think about simplicity. It's quite interesting because at the time, a lot of folks thought that messaging types of interventions would be passé quite soon, given the advent of smartphones and sensors. And it's just fascinating to see how we've kind of come full circle. And obviously the messaging interventions are quite different, but we're still talking today about generative AI and chatbots and so on. So there's still something about the medium that continues to live on. And so in earlier approaches, one of the things that we did is paired automated text messaging with ongoing interventions for depression, in our case, a group psychotherapy for depression. In order to really increase engagement, one big challenge in mental health and in behavior change in general, I would say in chronic illness, is getting folks involved in changing behaviors that need to be changed to improve chronic health, to manage illness. And we found that folks were attending twice as many sessions when we paired this automated texting system. And that really motivated kind of the next line of work, and also learned a lot of things during that work. Because I happen to be the provider and, on a shoestring budget running these groups. And people would often come into session and say, when we had a glitch, for example, a natural experiment, they would say, Dr. Aguilera, you forgot about us. And it really sparked that idea of the connection between the interplay between technology and the relationships that we build as providers. And I think that early on, a big mistake that we made was thinking that technology would solve it all, right? The killer app days of just kind of build the app and we'll solve everything. And I think we're learning through trial and error that we really need to find the right balance between relationships, trust, engagement, and then help technology solve some of the issues we're dealing with, but really lead with the people first approach and have technology support us along the way, rather than letting technology just drive the ship necessarily. So beyond that, Courtney and I have worked together, particularly to try to make some of these interventions a bit more intelligent, more personalized. So we applied machine learning to personalize messages to help people engage in physical activity. And I think the innovation in this approach was to learn whether machine learning algorithms could improve outcomes via personalization, but again, with the populations that we're working with. So these are folks in safety net health settings from low-income populations. So we're building the database from the ground up, as opposed to, let's say, training these databases on, frankly, populations that are more easy to reach, that are more engaged already in their health, and then try to apply them downwards. So we've found success so far there, finding that we are able to improve physical activity in folks with depression and diabetes. And then I'll just end with some of the things that we're doing now. It's a little bit less specifically focused on machine learning and AI, but it's thinking about a community-engaged digital health approach. And what we're doing is we're rolling out a existing app for depression and anxiety in primary care for Spanish speakers. So we're addressing a key need of linguistic availability. There are very few Spanish-speaking mental health care providers, even in California, right, relative to the need. And so what we're doing is we're partnering with community organizations and training community members who have relatively low levels of education and may not know as much about mental health, but they share lived experiences with our patients and can really connect at that level. So we're training them and having them support folks that are engaging with technology. So again, having this blend of the relationship and the technology.
Thank you. To the right. There you go.
All right, so this is my slide. Also, I followed Courtney's lead. Mine's not easy, and I'll just talk my way through it. So my research, my background is in public health and education. And then for my postdoc, I did an NIH TL1 biomedical and health informatics postdoc. Because in working with children who were medically restricted to home and hospital, I realized the importance of having the healthcare team included in the design process, and certainly in the deployment of any intervention. And so if you look over here on the left, I think it's your left, no, it's your right. On the right side of the screen for you, this is how it works. So this is from one of our recent publications on the power of robot-mediated play. So for 8 years, I studied the robots being used in schools for different learning activities. And the one thing I never asked a question about was playing. And as I looked at the data in aggregate, like 80-some% of the children used their robot for play. And they invented games. They invented all kinds of different things to do. This one little girl, I don't take pictures in my study, so I had somebody sketch this for me. She used her robot to continue to attend her dance class. And so you see her at home. She's on her computer. The robot went to dance class for her. And so the robot held her position in the dance lineup. And while the instructor was teaching the dance moves, the child at home was able to practice her dance. So that's how my research works. I use the robots as a tool for the child to remain active in their physical, organic environment. whether it's school, extracurricular activities, other things. And so let's see. So the child controls the robot around the physical environment. And so the reason the children are medically restricted to home is typically a secondary consequence of illness. Cancer, heart disease, immunodeficiency disorders, whatever medical condition is creating a very high risk of infection for them to be out in public. And so we all experienced that during COVID. This is something that children with these conditions experience frequently. And so then over here, I have some of our publications that, when you study humans, your publications are kind of everywhere because we study all the different aspects for which the technology has facilitated some type of interaction or experience, right? Because the robot is a robotic avatar of the person or of the child. And so everywhere we saw children, guess who we also saw? Grandparents. So right here in the middle, there's a grandparent. And so typically we have a little bit of hesitancy with older adults using things like robots, but if the children are using robots and it provides a way to interact with your grandchildren, we have found very high levels of motivation for older adults to also use the robots. And so this is at the La Plaza Museum in downtown Los Angeles. So it's a Mexican-American culture and history museum. And it's one of our community partners. And so we were doing research with the robots for COVID, and we had increasing numbers of people who wanted to use the robots, but have their families come to the museum while they remained at home, just for safety. And so in this particular slide, we did this whole thing, and you'll see the children are wearing masks. We still made everyone masks. This is when COVID was pretty high. And sure enough, the very next day, I got the phone call that someone in our group had tested positive for COVID, but not the grandparent. Grandparent was not exposed. And so part of this work in working with children, not just at home, but in these public spaces, is we want to grow junior scientists. So if we work with our community partners in public spaces, and we raise awareness of science careers, we raise awareness of robots in our society, technology in our society, and how they work. That's kind of the piece of equity that we do in our research. And so I was asked to do two slides, one the research focus and one my perspective or point of view. And this is something that came up during COVID. So during COVID, my studies kind of stopped because schools were closed. And so then everybody went online. So for the participants in my study, everyone else experienced what they experienced. But the one thing for me as a Spanish speaker, I instantly, even with my PhD, just became a translator. And so when we moved, the state of California moved to testing through Optum and Verily by Google. I kept trying to help people register for COVID testing or for, I guess it was COVID testing. That was the big thing where you could go to get free COVID testing. And the one thing in the United States is we, for equity, divide the entire country into two groups. Either Hispanic Latino or non-Hispanic Latino, right? So there's this straight division. And both of the platforms, that was like one of the very first questions. And when you're trying to help someone over the phone register for a free COVID test, and that's the first question, and then after we ask that question, we have another one. Are you Black, white, Asian, and I think it's First Nations, Native American. And so when you're trying to help people navigate this system, and they say, but I already answered that question, and then they would hit back, and then we would lose the data, and then we had to start over again. And it just became this very difficult situation to navigate on the phone, trying to help people navigate a system that had been deployed by the state that replicated our forms, but there weren't really any humans to help you with it. And it was all on phones. You had to, for the Google platform, you had to create an email. Many people didn't have a Google email. They all had to get Google emails, and then they started getting notifications and calling me to remove it. So anyway, from that whole frustrating experience, my colleagues and I, we created the assets-based inclusive design framework. And you'll see at the top, it's just really evaluating the cultural competency of researchers, health experts, and industry teams as we deploy community engaged research projects. It's like participatory action research, but with a call for social justice and allyship. Just really like stopping to reflect before you go into a community that is underrepresented. And when we talk about assets, really looking at identifying the assets to protect them, not to use them. So for example, children as translators, no. The children, yes, are an asset, but should be protected, not used by the power entity. Here we go.
Thank you. I think we're probably, okay, cool. So instead of starting with those questions that I said I would, I have a couple new ones that came up. Anyone who knows me and my background knows that I care so much about access to care. For me, it is a starting place, and particularly for those for whom it does not come easily. And all three of our speakers have spoken to that, and I'm hoping some of my questions, they'll tell you a little bit more about the details of that. The other thing I really appreciate is we hear so much about human-centered design. And I'd like to ask you, the three of you, about this sort of, and as it relates to technology. One of the things that I really like about working at Citrus is about that information technology in the interest of society part. And for me, the three of them really do work that works at that intersection. And so my question to the three of you is to talk, each of you to talk about your work from the perspective of the role of technology in promoting, increasing, whatever word you want to call, access from the way you design it. And I can tell you that none of them lead, it's not technology first, but it's technology with. So I'm going to go in reverse order, and I'm going to start with Veronica.
So the human-centered design is really important, I think, not only in my work, but in the tech spaces. And so I feel like we are at a societal frontier where we are moving into new spaces that are increasingly influenced by digital means. And so we either will replicate systems of harm, for example, the forms that were just put online, or the exciting part are groups like this where we can create better systems that are more inclusive and more focused on the humans and what we have learned throughout our history about diversity, equity, and inclusion, and making sure that the systems we are creating in these digital spaces are not simply replicating what has been done.
Adrian.
So I think I'll give kind of some examples. I think the user-centered design, human-centered design is absolutely crucial to developing new tools. I think that we also have to really think about, I always think about for whom, right? And thinking a little bit broader, not just a person standing in front of me, not just a focus group that came in, but how is this gonna go out into society? And I think when we've tried to use different tools, for example, IDEO's design kit, right, has a lot of really good tools to use to get feedback from users. But those tools are not necessarily accessible to everyone, right? And that's something that we've learned in some of our work in a project that Courtney and I are working on. An example is we were using this card sorting task for people to provide us feedback on the kinds of messages that they would like to get. And we asked them to, rank order them and see which ones they like the best. And really quickly, we started to realize that this exercise that for most of us who are highly educated is something that we've been trained to do for a very long time and now comes naturally. But for people who've been in school up until about 6th grade, let's say, it's not something that comes naturally to them, right? And so many of the ways that we conceptualize dashboards and platforms and feedback is in ways that make sense to us and to people around us, right? And so we really have to think not only about human-centered design, user-centered design, but expanding the base of who our users are, and really thinking, at least what I think is important, is who can benefit the most from this tool, right? And then trying to work on making our tools as relevant and including those voices as much as possible.
Yeah, I agree with both the previous panelists. I think what I would add, I actually was thinking when you asked about access to care, and the idea that technology will help us solve some of our issues with access to care. And I have two examples that I hope I remember the second one by the time I stop talking about the first one. The first is that, which comes back to our AI theme, so I'm going to try to bring it back. We've thought for a long time that technology will reduce the burden of in-person care, right? And 15 years ago, I was studying Kaiser Permanente's patient portal, the very first health system to ever launch a patient portal called kp.org, if you guys are members. And they launched it in 2001. They had secure messaging in 2005. So we were studying who used it, and we had lots of studies back then, and I could show you all of them if you want to see them, about whether or not that would reduce the number of in-person visits. And everyone was convinced, from a health services research standpoint, that it would reduce the number of visits because you could answer quick questions on messaging. And we're still doing that today, just like to point that out. And actually, every study that's ever been done has actually shown that it doesn't reduce in-person visits. And there are a lot of reasons why. It's a mixed way of communicating. When you communicate out to people, you find unmet need, not met by the healthcare system, that requires a visit that wasn't currently being met. You have new questions that come up that could be potentially dangerous, and there's liability reasons, and so you ask people to come in to get checked. It's a very complex system. And so I think when you're asking me a question, that's the first thing I thought about, because I see it in AI today. We're going to look through our electronic health record, and we're going to be able to use AI to predict who needs more visits or who we need to reach out to proactively. But there's so many unintended consequences of whenever you use a technology. And not that means we shouldn't use AI, although I have a lot of other thoughts about AI in terms of how we build it. But if we do use it, I think you have to be ready to really think about human solutions to that, because what happened is then we think, same with pandemic, we think we're going to be able to scale video visits at the way we did during the pandemic, and our workforce literally cannot support the number of encounters that people really want. And so that's like a societal thing that we think we're going to have to think about for a long time. So I think that, when I take an equity lens to that, that's just a real problem. The equity lens to that is, of course, that's differential by different groups, right? There's many things in there that allow us to be differential, and most of those unintended consequences are leaving out entire groups of patients. You're tapping into technology. It's almost universally known that most well-resourced individuals will use it first whenever you roll it out in your system. So then you have this immediate gap that you think is going to reduce gaps in care, but you're actually reducing gaps in care for people who didn't need more visits. So it's a very complex problem, and I want to offer you all encouragement that means it's an interesting problem to solve. It means there's a lot of technical things to think about, and there's a lot of non-technical things to think about, and that's why our multidisciplinary and team science approaches, I know we say it's essential, but I think hopefully that's a good example of what I mean by how essential it is to try to solve some of these problems. Yeah.
Thanks. Something else that they all have in common is that they have backgrounds in research, so they certainly know how to deal with data. And they all have the commonality of doing more implementation research, working directly with people. With that in mind, and also being so influenced by just the term AI this week, and the Daily that was looking at Google's Gemini and its attempt to compensate for biases. I wanted to throw out to the three of you, there are so many different kind of biases in our data that help in decision making, besides the ones that we used to refer to more societal, cultural, behavioral. But from the perspective of researchers, there's from research design, research analysis, the algorithmic one that they're talking about, publication biases. And of those, and you may have others, what would you say is the one or two most critical ones that we should try to address with regard to the kind of work that you do?
Oh, Gale.
Any-
I know, I could go on for this one. I think the big thing that I am most struck by in the AI and equity conversation is this idea that if we document the data sources and we document where they come from and we think about review of the models for bias by race, ethnicity is just one example, that we can solve the problem of bias. And I think even just your example, listing out the different types, again, go back to my previous comment, it's just really complex. And I think the biggest thing that I would like to leave all of you with is team science doesn't slow you down. It doesn't take you 10 years to solve the problem. It actually can help you go quicker to the solution of a problem. And for that, the data bias piece of what you're mentioning, I would say that electronic health records are one in which tons of people are trying to build AI tools off of, and there is just a lot of data missing from electronic health records. And no data scientist is going to be able to solve data that doesn't exist. I come from a technical, more like regression modeling background, and you can't fix the level of missingness that I'm talking about. It's not missing at random. It's not missing random. I mean, it is not present in the data, and that fundamental issue is not about documenting where the data come from and talking about the race ethnicity distribution because it's not in the data set. And I think that is the thing that I don't hear as much in the conversation. I hear people, and those are all great things, data modeling, model cards, being transparent about your data, sharing, those are all needed, but that's not enough to get us. If the data aren't present, that's a whole separate issue. And again, it goes back to a non-technical problem, like a systems problem that we need to really be solving together.
I mean, I'll just piggyback a little bit. I think that's an example of where innovation and equity need to happen at the same time, right? There's this rush to use all the data that we have at our disposal, but the quicker that's going to move, the greater the equity gap is going to be until we fill in the gaps of data that don't exist, right? So we really have to have this filling in of data happen concurrently. And I think one example of, one basic difference, a bias, an example bias that I see in some of the interventions that we do. I do behavioral interventions on how to help people change their behavior. So one simple thing that we're likely to see in the bias, and we see it already in ChatGPT and other things, is all of our health interventions tend to be very individual focused, right, on things that an individual can do. What can I do to improve my health? What changes can I make? Well, one, not everybody has the same level of resources or the same control over their life or their environment to have the same number of options, right? That's kind of one basic example. If we don't have the data about that, we're not going to be able to determine that. Another example is because it's so self-focused, we don't think about how in certain cultural contexts, relational aspects of health are going to be so much more important. So the utilization of family members, how those play, or different relationships and how those play a crucial role in health behavior, because we're likely to be a little bit more biased on what we can do as individuals, first and foremost. And that's not going to be the case even in the US with our diverse populations, and certainly not globally. Because people tend to rely on others, the fewer resources that you have. You have to rely on your social environment when you don't have enough resources to provide everything for yourself.
I agree with both, and I just like to add, for me, the one thing with bias is centered on motivation. Why? Why are we doing this? Why have we designed this intervention? And it really needs to go beyond developing something that saves us money, creates a new revenue stream, and so it goes back to kind of human-centered focus, and in healthcare spaces, it must be patient-centered focus. And all of the bias that goes into the AI and designing it for pulling the data, and looking at the variables. Again, the motivation for why were those selected? Why was the algorithm written like that? So motivation.
Oh, great. Okay. Next question is to you, Veronica. What do you see as the emerging trends with robotics and healthcare?
I think robotics are everywhere. So emerging trends in robotics is really for service robots, right? So we have two classifications. We have industrial robots that are used in warehouses, agriculture, and then we have service robotics, which is more of what we see in healthcare. And that includes the surgical robots, which are teleoperated by physicians. The robots I study are teleoperated by patients. It's this interdisciplinary team. It's this team science. I think that it is moving beyond just relying on the creators of the robots and believing what they say the robot will do. And so I'm seeing some really exciting teams across multiple disciplines that are coming together to help co-create and co-design.
Thank you. To Adrian, what do you see as challenges or gaps in this space of technology, health, and equity?
At the risk of being repetitive, I think I'm going to provide kind of another example.
Okay.
But I think that thinking about AI and kind of scraping all the data that we have, I'm involved with a project with some colleagues who wants to look at medical records and determining which types of treatments work for whom in depression, right? So depression is really challenging because even the best treatments that we have only work about 40% of the time, maybe 50% of the time. Behavioral approaches and even medication approaches. So we're not that great at those. So there is a push to try to figure out what works for whom, right? And it's a important thing to do to get those numbers higher, right? But again, if we go into the medical records and look at who is getting what and what the outcomes are, number one, the data is not going to be represented. It's going to be biased. And we especially don't have as much data on the social determinants of health and the social picture, which is impactful for all of health. I would argue even more so for mental health, right? Where just being exposed to one traumatic event is going to multiply your risk of having mental health problems by 2 or 3-fold, right? So that's one example of the promise, but the challenge that we're continuing to face.
Great. And so, Courtney, to you, how about opportunities that are just either right in front of you or seem like they're within reach?
Opportunities. I think there are so many opportunities. If I had to give you all a few, I think this is the first, I feel really inspired of how much we're talking about equity in AI. I think the opportunity of that is actually within reach. I don't think it's a solvable immediately in 1 year problem, but I do think it actually is something we could solve if we can do some of the things we're talking about today, which is have different teams, have different processes, really think critically about the problems that we need to solve and which tools we need to develop. So to me, that I know that's a big one, but that one's a pretty big opportunity. And then I would say through some of our projects and things we've worked on, engaging community and really centering our work on what they're interested in. I just can't tell you how much opportunity there is to solve really important and really intractable problems that I've seen researchers be scared to try to solve or feel like they don't know how to address social determinants of health. How could I do a project that addresses that? But there's just so much opportunity and frankly, more people wanting to, I'm on NIH study section, write grants on that or work in that space. So I see those as two really amazing trends that I don't want it to just be a 2020 COVID and social justice moment. I would love for us to really continue that into the future.
Thank you. Well, I do have more questions, but I'm also cognizant of time, so I thought perhaps we could open it up to all of you. And if for some reason you're quiet, I still have a list.
Hi, can you hear me?
Yep, but I think someone's running to you with a microphone.
Okay, so I sit on the DEI committee, advisory committee for epic medical records.
Oh.
And at the last meeting,
Come on up.
we had a very interesting discussion that one of the big problems that hospital systems see are no-show patients. So they had this brilliant idea, we'll have a rubric, we can predict who's no-show, and when we predict those people, then we'll double book. So of course the people they predict as no-show are Black and brown and poor, and then when they do get there, someone's already there for their appointment, so they wait longer and have less time. Now, this is a room full of doctors, and I'm a nurse, so I was like, if I were going to address this problem, what I would do is look at the data of which doctors had the lowest no-show rates and which had high ones, and look at them and change them, not blame and shame the victim. So I do think like there's data out there, and then we look at it wrong.
Wow.
Well, and just one, thank you for being there.
Yep.
And I think that's a really good example of
good.
sometimes just focusing on the what and not the why, right? We're focused on the outcome, save some money, instead of stepping back and asking ourselves, why is this happening? And can we move upstream to try to prevent that from happening instead of just thinking about the bottom line and further increasing the gaps?
Yeah, love your comment. Exactly what the multidisciplinary team. I mean, the fact that you were there and you could bring a different perspective. Yeah, and then some of the data are there, like the clinical teams, and I would say some of the data aren't there. We're not really always asking patients why they weren't able to show up for their appointments or what we could do to help them do it. And I've seen a lot of data scientists say, well, we're just going to go into the note and pull out the social determinants of health and look for transportation as a barrier, and then we'll give those patients a transportation intervention, but who are we asking about transportation barriers, and how are we, like there's just so many levels of system level questions that actually, again, a nurse, frontline person who's actually in the clinic doing it could give you a much better idea of what's actually been asked and how systematically and what data are good, but we don't always do that. And that's a simple thing. You can just bring somebody in and talk to them.
I really like that perfect example of bias, right? And somebody wrote it out, and we will predict based on our bias because it's a they problem. Nice.
More questions? Yes.
Hello. Yeah, so I think Adrian talked a bit about like using AI to personalize messages to help people engage in activity, and that was like a successful way to do that. And I know that often there's like a problem with getting people to adopt like the technology that we develop, even if it's like beneficial for them. So in general, what are some ways, both like through maybe machine learning or other ways, to get people to really adopt and get the best out of like the technology that's developed?
So I think a couple of things briefly is we really need to find the motivation, right? Why would people want to engage in X behavior, right? And that's just even me just speaking as a psychologist. That's really how we're gonna get people to move, to get going. If we don't get any why, if somebody's not convinced that this is a good idea, they might tell you, sure, I'll do this program, and then just never look at it again because they're not bought in. And then the second thing that is important is some sense of connection to something, some sense of trust, right? So in this study, where you have to look deeper, but it looks like the people who were kind of patients within the healthcare system and received the program that way did a little bit better. And we think it's because they have trust, they have a connection, right? Again, you're building that motivation. I think the relationships are also important, figuring out where the barriers are. So I think machine learning can help us figure out where are people exiting and how can we maybe then give people targeted intervention from a human in some way.
Adrian knows me well enough to know I'm going to go into theory, but it's going to be good because motivation is one category. Opportunity is another one. It has to be easy to use. And he already mentioned an opportunity queue, which is who is offering it and what context are you offering it. And then the third is capability, which is really about, do people have the skills and the resources to use what you're designing, which often, even though it seems obvious, is actually often left off the table. It's only in English. It's only in this format. It's written at a 12th grade reading level. I mean, those are things that technology should be able to solve for us, but we don't often actually use them to do any of those adaptations, even though we could do a much better job.
For machine learning, one of the emerging things is shared decision making. And so, whenever I look at that aspect, right? So people are making some very serious decisions about their health, about their family's health, is really understanding that the tools are supposed to help reduce the cognitive load so that you can be more present in that decision making. So for example, your study, right? The motivation, why would a text be helpful? And if it's making you feel more connected, if it's making you feel more heard, more seen, so that you can be free to make those decisions about your health or your family member's health.
I had a question regarding how we measure how good an AI is, right? All of you have probably thought of AI in different contexts, right? Like natural language processing, or sometimes when I'm developing it, I'm thinking about accuracy and false positive rates and false negative rates. So what I'm trying to ask is basically how do you evaluate if an AI being used in healthcare is actually good as or better than a healthcare provider in a certain case?
Such a good question. And what I'll say to you is I was just at an NIH workshop on AI and ethics. And actually, one of the things that experts in the room were saying is that we don't actually have a gold standard for that. We're using different ones, accuracy, we're using all sorts of different models. So I know we all have ours. We all think we know what we're judging it against, but actually we're all talking about slightly different things. So that's not very promising, but what I'll say is that we're trying to come up with some better standards for what to report on. So that's one thing I'll say. And the second is that for me, I care about the accuracy of the model, but for me, working in a healthcare system would be a more real world test of it against the usual practice, which is often very far from where the model has started. And so I haven't seen very many papers that have been able to do so. Because it's multiple steps removed from the original, but that's what I would be looking for. And clinicians are a tough bunch. I mean, I don't think the accuracy in one paper is going to move the needle on them accepting an AI tool in their practice, which I know probably all of you know, but I just want to say that again. I've been in many, many rooms with many of them saying, radiologists, which we have the best examples of AI, saying, if it can do better than me, then it should take my job. Not worried in the slightest that AI will take their job. Yeah.
Yep. Same in reviewing for HHS, the proposed measurements and assessments are all over the place. It's emerging, it's evolving so quickly. There really aren't any gold standards, and it's really looking at how thoughtfully they're looking at the variables. So I think it is right now just task-based, right? You're collecting this to determine that.
Yep.
And is it valid?
Got it. Did you want to say something brilliant, or we'll take another question?
I'll just add that I think there's some value judgment in that, right? So what matters? So the example we heard earlier was the AI is most impactful if it saves us money and time slots, right? Or accuracy. And so I think what this calls on us to do is to think about what are the metrics, right? So how can we embed equity metrics in this? So if we say accuracy, for whom, at what level? Is this accuracy similar for everyone or for a certain group? And so I think those are the kinds of things we need to think about.
Thank you. One last question.
Yeah, hi, this is Suresh. I'm not a healthcare professional, but somebody who's from the technology side trying to go more into the healthcare side. I'm fascinated by the discussions, but one of the things I constantly hear is that we don't have either good data or enough data or quality data. But at the same time, when I look around, there are so many people who are not so healthy. So data is obviously being generated, and it seems like it's sitting in silo in one hospital or one institute. What are we doing to bring that data together? As a technologist, it feels like if you can anonymize it, there's tons of data that could be curated. So I'm just curious, what is preventing us, or what is happening to let's say, dismantle some of these barriers? And then secondly, could generative AI help us to actually even create some of the synthetic data, and maybe some of the work is being done on that?
What a great question, and what a challenging one for them to answer briefly, but we will give it a try.
On the same NIH panel, we actually had a multimodal group, a synthetic group. We talked a lot about this. I think what I'll say to you is there are a lot of people trying to work on that problem. It's very difficult in healthcare. There's a lot of commercial interests that protect data in addition to liability and compliance and legal reasons why we don't share more data. That's one answer. And then the second answer is even if you're in one healthcare system and you have access to many points, which is I'm fortunate enough to do, the more sets of data you connect, the worse some of the missingness of the data become, because of how we refer people through our system and how they're represented in the data. And so we really, yes, there are opportunities, but there's these structural things, not technical problems, that are holding us back. And then once we get to the technical problems, I think we really need some sophisticated ways of thinking about the data, synthetic in other ways, because it's not going to be whole, even if we're able to link it all together.
I have a quick example. When I worked for the state of Montana, I also worked with Adobe on transferring a lot of our federal maternal child health block grant forms onto a digital platform, because like you, I wanted to see the data so we could fix problems. And we identified a lot of oral health disparities across the state. Specifically, there were some areas where 100% of the teenagers had untreated cavities. But then what did we do? We didn't have money for an intervention. And so kind of collecting the data just to collect the data just left us feeling more powerless because there wasn't a plan. So we do live in a world where we could collect like a ton of data, but unless it serves a purpose and funding to do an intervention, we just identify a problem and we kind of give black eyes to communities that maybe were already in a vulnerable position.
I'll add briefly, I think some of the systems that have data from the most vulnerable populations are the least likely to share that data. There's some policy issues. Part of it has to do with protecting folks. I think the flip side is sometimes then we don't include that data. So that's a really important problem that's more of a policy issue. I think another thing to consider is it's really important to look into the EHRs, but that's not all of the health data. Health data lives out in the world on a daily basis, and looking at just health means we're so biased on downstream versus upstream.
Yeah. Thank you, Courtney, Veronica, Adrian, and thank you to my Citrus colleagues for putting this on. Thank you all.